nobody knows your body like you do. And because this idea is so prevalent, even if you have the normal mammograms, even if you have your normal checkups, cancer is sneaky. You have to catch it. It's like a little kid wanting to kill you, right? What I'm going to ask you to do today is take out your phones. Yeah, I'm going to wait. I can wait. Take out your phones. I know this normally doesn't happen in a WebEx, but take out your phones, turn it on, put in the code, go to your calendar program. Press a little plus. If you have an iPhone, it's the upper right. You press a plus. And in the title, you're going to write breast self-exam. And you're going to add that. You are going to write in there the time of the exam. And you're going to type in 10 p.m. And then you're going to press repeat every month. Not done yet. Go down a little lower. You're going to press alert 15 minutes before. This is your monthly breast exam alert. And you can do it, make it like a meeting on your phone, and it's ready to go every month. Now, I say I would never take it away from myself or my family. I want to talk about all of the good things that have happened because of breast cancer. I find myself more empathetic, more caring. I would have never gone to Kellogg. I wouldn't have had the bravery to start a company. Closer, deeper relationships. And quite frankly, I think that we are here on this earth to help other people. And there's also been changes in my husband. The I can fix everything mentality. You can't fix some things, and it's okay. The standing by to watch things unfold, teaching patience. I have 3 sons, changes in them. They were wonderful human beings to begin with, but I noticed my oldest son, he likes things all new and shiny. And when they break, he likes to get rid of them. And he learned we don't get rid of broken people. We don't get rid of people when they get sick. We help them feel better. My middle son, he loves music. And he realized that playing music helps people's souls, and it helps them feel better in a time where they're hurting. My youngest son, full of life, just wants to go, 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 go. And he realized cuddling, sitting, reading quietly alone with, together as a family, all of these things matter and they have purpose. So for all of the things that cancer cannot do, and for all of the things it did for our family, I do appreciate it. If anyone has trouble putting the alert in their phone, let me know. That and the cancer awareness of nobody knows your body better than you. I have found that laying on a hard floor gives me a better idea of my breast tissue and being able to do the self-exam. A lot of people say in the shower, the doctors will tell you what is the best practice, but I like a hard surface because you can feel things better. So with that, I am gonna introduce our next amazing speaker, the Mother Teresa of Breast Cancer Hub, Dr. Lopamudra Desroy. And I appreciate you letting me speak to everybody today. And happy Breast Cancer Awareness Month in October. And let's make it Breast Cancer Awareness Year. Thank you.
That was so amazing, Evey. Like, as I told to everyone that No one can be as inspiring as you, and you made us all sign up on the calendar. So that's the next step. And thank you for doing that. And I thank you for the generous introduction. I don't know, I'm a little fumbling with the introduction, but I would definitely try to do justice to whatever, and thank you to everyone for believing in me and for believing on Breast Cancer Hub and coming here to listen to all of us today. So I'm going to start off, and I hope you all can see my presentation and I'm clear on the screen and with my voice. So the topic, as Evey started off, is very important for me because the breast self-examination, and Evey has already put a step on that. So that is what will be the primary focus. But before starting off, I would like to start with a tribute to two of our amazing women who left us with breast cancer, and they are our motivation. And thank you to the families for giving me the permission. So Mrs. Lotika Das, like I know that we all think of the screening process, like we think of big words, we think of mammogram, we think of MRI, we think of ultrasound, but something basic that we forget, which is the taboo, because we do not speak about it, and the ignorance part, because if Mrs. Lotika Das had known that a painless or painful lump could be cancer, she wouldn't have kept quiet and she wouldn't have shied away. So whose responsibility is it? It is each of us over here now. I give you the authority and the power to talk to everyone, irrespective, be it a man or a woman. You need to help the other person, help your friends, tell them when you meet up, during the parties or, in any get together, instead of asking, of course you can say like, you look beautiful, your sari is beautiful, but ask them, did you do a breast self exam this month? That is important. Make that a discussion of your agenda. Like that's an agenda for each of us. And because they keep, like, all our advocates, our survivors, our breast cancer hub support family, that keeps us going. And I cannot be more grateful to have each of you in my life today. And it's not only about women, men get breast cancer too. That's why every time I see a pink ribbon, I always request, put a blue touch on that. I know it is 1 out of 883 men can get breast cancer. That's the current statistics. It's not like 1 out of 8 women, like we so frequency, but aren't they? One man is a father, he can be a brother, he can be a son, and we cannot forget them. For us, we save a life, we save a family. So a lot of men, when I travel to India for all the outreaches, 99% of the men, they do not even know that men can get breast cancer. And even in US, a lot of places it was not known. And we collaborate with Male Breast Cancer Coalition. And I cannot give them a bigger shout out because for them, a lot of men are speaking up. Because for men, the situation is worse than women. They think it's a woman's disease. And that's why they are more shy to talk about it. But because of this amazing organization, because of, Brett Miller, the founder, and other survivors, and Patricia, her husband's picture is on the car. You can see late Marlene Washburn. Marlene did not know he was having breast cancer. When diagnosed, he just had 5 months. But Patricia has the picture in the car, and she travels all across US so that other men get to know that they can get breast cancer too. And it is also like for each man over here, please check yourself, and we will get to that discussion next. Now, coming to a little bit of statistics, like why in the developing countries, the survival rate is significantly lower as compared to the developed world. And most importantly, it's taboo and the ignorance through the experiences that we had and the lack of research also. Like when I do the Google, I find out like what is the survival rate in, for example, in India, I see 60% survival. But do we go deeper and see the repositories from where the data is being drawn? Because when I'm going to a village, it's like 100% death rate. Where is the data reflecting? So where is the actual? So that's where we are trying to tap into the untapped regions, the untapped areas. If someone could, I think someone might have just entered. If you could mute yourself, please, that would be very helpful. Or if the co-host, that you can mute the other person who is actually speaking, that would be helpful. Yeah. Thank you. Now, so what are the screening processes? So basic screening processes, we know the gold standard is mammogram. And what is mammogram? So mammogram is low dose ionizing radiation, but it's regarded as one of the main screening processes, the gold standard. Now, when I do a poll, when I do the outreaches in India, and when I do a poll, it's only just, I think, 0.2-3% women actually go for screening mammogram after the age of 40. Even if they're aware, it's not about the socioeconomic condition. We prefer to buy a sari rather than spending 500 rupees and doing a mammogram, because it's a culture-induced, the taboo that we carry on. And I do not blame anyone. The other thing is, mostly what I found, women going for the screening is actually for diagnostic. That means when they have issues, they reach out to the doctors. But that's not the purpose. Screening means we need to do the screening when the disease is not there. So that is how we can detect ourselves very early. And mammogram, the standard now, according to the American Cancer Society, is between 40 and 44. We have the option. We can go up to the doctor and we can do the mammogram. Women 45 to 54 should get mammograms every year. Women 55 and older can switch to mammogram every other year. But what happens to the younger women? One good thing in US is that doctors do clinical breast exam, right? But when I go to India and I request the doctors, there are a lot of male doctors are telling me, are you kidding me that I'm going to touch a woman's breast to do exam and she's coming for some other condition, for stomach pain? That is like a totally no-no. A lot of women gynecologists told me it's very difficult. Women will say, why are you touching my breast when I haven't come for this particular issue? So, but then, it's only now a lot of doctors are trying in India their best and they are coming, but it's just the surface level we are touching. The full majority is still left. And I request, like, you as a candidate should go and voice your opinion and request the doctors, do my clinical breast exam. So that is how we can bring the change, we can bring the impact. And the most importantly, like if you're at high risk, if you have a genetics factor, for example, like if you have a family history and if you're carrying this mutation called BRCA1, BRCA2, then like, for example, if your mother, aunt, your first degree relative, having ovarian cancer or breast cancer, do the genetic testing. And if it comes positive, then definitely you need to go for the screening earlier. From the age of 30 or something like that, consult your doctor, but be on top of it. Because as Evey mentioned, it's your own body. You have to advocate for your own body. And you know your body the best. Now, what is another important aspect I want to discuss is that, did you know that mammograms can also miss tumors because of a situation which is called dense breast? And 60% of the women will have dense breast. I myself have dense breast. So what happens? Just an overview, mammogram is an X-ray of the breast. So when we do mammogram, the image appears like this, like a black background, which means it's fatty tissue. But when we have dense breast or fibroglandular tissue, it appears as white patches like this. And if we have heterogeneous, it will be scattered this way. And if it is homogeneous, like full dense breast, it will appear white patch. Why are we talking about dense breast? Because if we have a lesion, it will appear like a white dot. And it's like finding a snowflake in the snowstorm. That's how 50% of the cases with dense breast, the tumors may get missed. And what is the next prognosis? And we are so thankful to Dr. Nancy Capallo, because her tumor got missed because she had dense breast, though she was doing mammogram every year in 2004. And when she got to know, when doctor was doing clinical breast exam, that's when they found the lump. She did an MRI and it came on stage 3C. With breast cancer, stage 0, stage 1, stage 2, stage 3 is 100% curable. With stage 4, also, like, when it spreads to the different parts of the body, we can still treat them. We can we can definitely treat the condition, but it's always better to be detected early. So what's the next step? Here in US, we are now preferring 3D mammogram or tomosynthesis, and that's like better resolution. But in India, are we still doing like the normal mammogram? In that case, let's do an ultrasound in addition if you have dense breast. So check your report, if you're having dense breast, and if you still feel a lump, go and ask your doctor, maybe we need an ultrasound for that. And of course, your doctor is going to tell you. So think about the additional tests. But the most importantly, now I'm going to come to this part, which is breast self-examination. Because as I said, like, when I thought of starting Breast Cancer Hub, and my first thought process was, if I'm going to India and talking about doing mammogram, because like many times I asked many women, they said, I did mammogram. I asked, when did you do it? 5 years back. Mammogram is not like, you do it once in a lifetime. You need to do it every year. But then what next? So that's when I felt like the way doctors are saving our lives here through clinical breast exam. We collaborated with Male Breast Cancer Coalition and Sarah Cannon Cancer Institute, and we developed this protocol, like what doctors do through clinical breast exam, we do the proper way on ourselves. And I don't have time to go into detail, but as Evey said, sleeping, hard floor, definitely, whichever way, like, keeping your hand behind your head in a sitting or standing position, and in a sleeping position. Then check the underarm areas also from the collarbone. It doesn't mean that it's only the breast area, the full chest area, underarm, everywhere you have to check. Look for any signs and symptoms. Stand in front of the mirror, go behind, put your hand behind, and any discharge, any pitted skin, like the skin of the orange, or any inflammation, any redness, anything, please, it is an alarming sign, but 95% cases, it will be benign or not cancer. But still, it's better to be safe than sorry, because, a lot of times people tell me there's false negative, false positive, but please, monitor that lump. If you find anything like a marble shape or like a mustard seed, check the next month. But when to do it? 7 days post-menstrual cycle. And if you're on menopause, or for the man, pick a date in the month, because a lot of time during your period, you may feel a lump, but it will dissolve. So please download, like you can go to our website that we have in 18 languages, because when I'm going to the villages, like for example, here in Hyderabad, I gave it out in Telugu and Urdu, and that really works wonders, because the local languages, that is how we are able to penetrate, and we are able to really, really save a lot of lives in the last few years because of this simple protocol, free of cost. It covers the taboo, and you should know your breast the best, so that you can actually, any abnormalities, and you connect to us if you do not know of a healthcare system, because as I said, we take accountability of each patient, or if someone would reach out to us, we will help you to navigate. And that's how we kind of complete the end-to-end process, and we know that we could save lives with that. We have penetrated deeper into the villages now. Sanal MD Devi is here, who is our project coordinator, and amazing work the team is doing, going to every household, taking the database, teaching the breast self-exam, and any issues, we are taking them to the hospital so that we can detect early. So now that was all about the early detection, and then how, the screening processes definitely helps, and saving lives with this protocol. I'm not saying do not go for mammogram after 40, you have to, but I'm saying that every month check your breast from the age of 17 to 18 years, because an 18-year-old girl I met in India detected last stage during my outreach. And so that's where, though the protocol says 20, but I know if we had met this girl earlier, we could have told her that this can be cancer, go to the doctor. So that's why, 17, 18 for men, also for the boys, please start checking yourself. Now, a little bit, this is my last slide. I just want to touch base on the preventative measures. 30 to 50% cancers can be prevented with lifestyle, but a lot of times environmental factors play a role, which is not in our control, but what is in our control, we need to really take care of that. Tobacco, smoking. Smoking is not only about lungs, it goes to so many types of cancers can be affected. It's not about 1 cigarette or 10 cigarettes, it's about nicotine. It's a carcinogen. And if we stop using tobacco products, we're also doing a campaign on tobacco. The villages we adopted, every household is chewing tobacco. And it's not only restricted to the mouth, it's going through the, in our full system. And we are directly putting carcinogen in our body, which is an agent causing mutation in the DNA leading to cancer, leading to the cell divisions. Now, the other factors, I touched base on family history, alcohol, we need to reduce the intake of alcohol, ethnicity and the race plays a role, obesity plays a role, and definitely, inflammation. Inflammation plays a dual personality. Without inflammation, we cannot repair any damage in our body, but inflammation, if it goes out of control, it definitely triggers the progression of the cancer also. So if we have any diseases, for example, arthritis or any other inflammatory condition, condition, please keep a check on it. A lot of diet, which you will find is anti-inflammatory. We have a lot of published data. Look it up. There's anti-inflammatory food also, like fresh ginger, fresh garlic, then turmeric. The byproduct of turmeric is curcumin, which is anti-inflammatory. So there are different ways. Most importantly, exercise. 20 or 30 minutes of exercise a day is really, really helping in the stress level, because these are different factors. They act in a cumulative way and help in the, like a lot of times it's not only about cancer, it's about other diseases too. So just wanted to touch base on all of these factors, and any questions we are going to take at the end, but definitely, I cannot do it alone. Each of you have to step up, break the shield, break the barrier, and we all need to scream and say, break the breast taboo. And you just have to do it for me, for each survivor and each patient, for the families. Thank you so much. Thank you for being here. Thank you. Thank you so much. So I hope, so I spoke about the early detection, the diagnosis part, and we have an amazing speaker now, and I'm so thankful to Dr. Sandhya Ravi, co-founder and managing director of Prameya Health Private Limited, and she's a consultant general breast cancer surgeon. Now, who is going to take you to the next part, which is like, what do we do when we are diagnosed? I spoke about the early detection or detecting, like what do we do next? Over to you, Dr. Sandhya. You have to unmute yourself.
Just a minute, Lopa. I'm trying to share the screen.
Okay, sure. Absolutely. And
oops. Is it seen now, Lopa?
yes, we can see Dr. Sandhya.
Okay. Unable to. Yeah.
Perfect.
Yeah. So thank you, Lopa and Breast Cancer Hub, for giving me this opportunity to speak in the month of October about breast cancer and the surgical implications. I'm a breast surgeon, so I do see a lot of patients with benign breast diseases as well. And like Lopa said, even if I'm a general surgeon too, so even if they come to me for a bottom problem, I do tell them that I need to examine their breasts, and they are shocked. They say, I've come for an acute bottom problem. I have an acute fissure or bleeding per rectum, but why are you looking at my breasts? But that's an opportunity which I'm not going to miss. And I do tell all the gynecologists who are friends of mine that they have an immense opportunity as well, because they are the first point of contact for a lady. She goes there for, pregnancy or a delivery or some gynec problem, and they shouldn't miss that opportunity as well. So this, like Evey said, a diagnosis of breast cancer is devastating to a woman wherever in the world she may be. And just yesterday, we had this webinar on whether the breast cancer incidence in India in the urban group is much more than the rural. Yes, it is, but India still ranks third after US and China in breast cancer. The number of breast cancer cases in India are rising. The burden is very high in the urban places. But what I have seen in my last 35 to 40 years of practice is that we are actually seeing stage 1 and 2 breast cancer cases now. When I was a resident in the regional cancer center, we were seeing stage 3, stage 4. Almost 75% of the cases were locally advanced or metastatic. But now it heartens me to see that we're actually seeing 50% of the cases are early. So the breast cancer awareness programs are actually paying off. So what happens? A woman is diagnosed with breast cancer, and they're really, they're very confused. They don't know what is happening. They need to discuss options. And most of the times in India, people just hope that they can wish it away. They could just pop a pill and the cancer will go away. So they're not even ready for, the array of treatment options that we're talking about. So the minute a cancer is diagnosed, what we need to do is the workup. we need to stage. We need to see whether it's early disease, whether it's locally advanced, whether it's metastatic. So stage 1 and 2 will be early. Stage 3 is locally advanced, and stage 4, where it's spread to the different parts of the body, is metastatic. The biopsy report can also tell us what grade the tumor is. That is actually to see how fast it's going to grow. Then we do certain tissue tests, which are called, they are the markers, biomarkers. The hormone receptor status, that is the estrogen and progesterone receptors. Then we do what is called the HER2 status. So that is the growth factor receptor status. And then for people who, where it's warranted, we do the BRCA1 and 2, especially if they are young patients, and triple negative, which I'll be talking about a little later. And of course, we do a series of gene expression assays. But by and large, what we normally do is only the grading of the tumor, the hormone receptor status, and the HER2 status. So we've all heard of this, responding to hormones, the ER/PR status, and the HER2. So this is what is mandatory now as part of the biopsy report. So we're looking at estrogen progesterone, which is normally secreted by the body. And we have receptors on the cells. So when these cells have the estrogen and progesterone receptors, the hormones can go and activate the cells to grow faster. And there are also the other receptors called, there's a protein on the surface of the cells which controls how the cells grow and divide. And the high levels of this HER2 proteins are also can stimulate breast cancer growth. So by and large, 70 to 80% of all breast cancers are either ER or PR positive. It can occur in various combinations. 15 to 20% of all breast cancers are HER2 positive. And there is another variety of breast cancer, which now we're seeing more and more in India and more in the younger age group, in the 40s and early 50s or even the late 30s, which is called the triple negative breast cancer, where the ER, the PR, and the HER2 is negative. So why do we need to know this? Because this actually impacts our treatment plan and also impacts the prognosis. Generally, people who have ER/PR positive tend to have slow growing tumors, less aggressive. HER2 also, even if they're positive, we have a treatment option. We have something, a targeted therapy that we can offer to the patients. But if they're triple negative, we are less, at the moment, as on date, we are left with very little options other than just chemotherapy and maybe some immunotherapies. There's a lot of research which is happening there. But I'm quite positive that we will have a lot of good drugs and good options for treatment of triple negative as well. So like I told you, there are a lot of options available for treatment, and decision making is very, very difficult. So, people are either have to rush through it, they're very anxious, they want to get through treatment very quickly, but you must know what options there are. You must ask questions to the doctors, and you must be prepared. You must know what's coming up, right? So you have to remember that treatment varies from person to person. It depends on so many things. It depends on your age. It depends on your other health status. And actually, it depends on your preference as well, as I will tell you. So treatment can be done in various combinations. I've listed out surgery, radiotherapy, chemotherapy, hormone therapy, and targeted therapy. All of these we use for breast cancer treatment, but they're given in different combinations. They're given in different sequences. So talking about surgery, we do have different options here. Again, for early breast cancer, we do what is called a breast conserving surgery, where your breast is preserved. Only we do a wide local excision of the lump, and we will remove, we either do a sentinel lymph node biopsy or remove the lymph nodes from the axilla if it is warranted. In some cases, even for early breast cancer, we do a mastectomy, that is removing the whole breast. This is especially if your mammogram or the MRI shows multicentric tumors, or your tumor is very large compared to the size of the breast, or if you are gene positive, if you're a BRCA1 and 2 positive, then we do a mastectomy. So these are the two surgical options. And when it comes to lymph nodes, again, what I want to point out as a surgeon is over the years, less has actually become better. So when I was training, we were taught to do a radical mastectomy, modified radical mastectomy, and then quadrantectomy and so on. But now more and more cases are amenable to wide local excision, breast conserving surgery. So we're not knocking off the breast in the majority of the people. Even in India, in the urban setup, we do have an opportunity to do breast conserving surgery. So less is really better. And even when talking about axillary lymph node dissection, we're talking about sentinel node biopsy. That is, we're just choosing one, we're mapping the node. So we inject a dye into the tumor, just above the tumor area into the skin. And that is picked up by the lymph nodes. So if we can identify a sentinel node and biopsy that and find that it's positive, only then we go ahead with operating on the remaining nodes. If it is negative, then we don't touch the axilla. So what does all this mean? It means that we are actually reducing what we call the morbidity, the complications of a procedure that we are doing, not just the complication of the cancer itself, but just our treatment itself causes so many problems many times. And over the years, it's been refined and refined and refined, and so much of research is going on, so many clinical trials, which have actually told us that less is better now. And of course, going back to the other treatment options of radiotherapy, chemotherapy, there are so many other improvements there. Whole breast radiation is now reduced to accelerated fractionated radiation, hypo fractions, and so on. So again, there are lots of research. Nothing has become standard now, but lots of research to show that probably we don't need to do the whole breast radiation, 25 fractions, 5 weeks, and so on, radiate axilla. All of those things will probably change over the next few years or maybe a decade. Chemotherapy, again, lots of options, but again, the timing of chemotherapy is important. I'm not going into the different drugs that are being given for chemotherapy. For early disease and for triple negative, there are various options that we do. And hormone therapy forms a very, very important point of care for breast cancer patients, especially those who are ER and PR positive, estrogen receptor and progesterone receptor positive. And if they're postmenopausal, it really is very beneficial. We usually give hormone therapy for about 5 years, sometimes 10 years too. And those who are HER2 positive, they receive targeted therapy, that is the Herceptin or trastuzumab, pertuzumab. There are newer drugs there. And all these can be given even before surgery. So these are the markers that we do at the time of biopsy. So then we can plan the surgery very well. So as you see, there is a very confusing array of therapeutic options that are available, combinations that are available, and you will have to understand what your disease is. It's not the same for every woman. You cannot compare. You know, somebody had this chemotherapy before surgery. Why am I having chemotherapy after surgery? Or, you know, somebody had a mastectomy. Why am I having only a breast conserving surgery? Somebody, even though the tumor was small, why am I being recommended a mastectomy? These things are important for you to make with the treating surgeon, the doctor, the oncologist. So you must be well informed. And it's wonderful to have supportive care groups such as Breast Cancer Hub, because there's so much of discussion going on, and there is really much more than what a doctor can sit across the table and talk his theory. Whereas, you get a lot of insightful information from patients who've gone through this, who can give you some suggestions, and with which then you can go back to your doctor, discuss, and make very informed decisions. So coming to the side effects. Now, like Lopa told you, I run a preventive and a supportive care organization. We do a lot of breast cancer supportive care work. And as a treating oncologist working with breast cancer over the years, what we have found is treatment alone is not sufficient. Supportive care forms such an important component of the way a person comes out of this, this diagnosis and treatment. So this is something we must pay attention to. And, towards the second half of my career is when I decided that I must pay more attention to this and help patients. So what we've looked at is the side effects are not just treatment-related side effects or disease-related side effects. They can span over a period of time, immediate, delayed, long-term, lifelong. They could be physical and emotional. They could be related to body image and sexuality. They could affect the fertility of a woman, because we are seeing more and more younger women in India. The demographics is changing. So we are seeing people, like Lopa said, she saw an 18-year-old. I'm seeing people in their late 20s, early 30s, early 40s. So, and many of them have postponed childbirth because they were, more focused on their career. And then breast cancer just shows its ugly head. And then they realize it's too late to have a baby. So what are they doing? So those concerns too are bothering a lot of people. All of us know that the primary side effects are, fatigue, sleeplessness, anxiety, all of those. From the physical domains, there are lots of those things. Body image issues, particularly today, I want to speak about this condition called lymphedema. Now, when I have patients coming to me and we starting treatment, the first thing they say is, will I lose my hair? You will be surprised. Nobody even knows about lymphedema. And most of the treating doctors don't even speak to them about lymphedema before the surgery, at the time of surgery, or soon after surgery. Only when it happens, they say, oh yeah, it could happen because you've been, your axillary lymph nodes have been removed or you've had radiation. So 1 in 3 women who've undergone treatment for breast cancer are at risk for lymphedema. Can you prevent it? Absolutely, you can. Once it occurs, can you cure it? You can control it. Sometimes, it's there with you for the rest of the life. There are lots of things that you can do if you have paid attention to it, if you are aware right before your surgery, through surgery, and if you've been following certain things. So how it impacts quality of life is, it's disabling. You're helpless. You're seeing an arm which is swollen, you can't do anything about it. And if you have to manage with lymphatic drainage, manual lymphatic drainage, massage, arm sleeves, it's a lifelong, time-consuming process. It affects your body image, absolutely. Though there are lovely, arm sleeves now, which are very stylish, and you can wear it with a flare. But it does reduce your self-esteem, and it's a constant reminder, unpleasant reminder of what you've gone through earlier. So these are the 4 things. The backbone of preventing lymphedema is that you exercise regularly. A lot of people think if you've been operated for breast cancer, you shouldn't move at all. Especially in India, they think I can't do any work. But you must exercise regularly. You must wear compression bandages. You must take care of your skin. So these are things that can be taught in a supportive care group, because in a busy hospital outpatient, no doctor has the time, nor does the patient have an inclination to discuss these important issues, which are seemingly inconsequential to both the doctor and the patient at that point of time. And then, of course, manual lymphatic drainage, which has to be taught by a trained lymphedema care therapist. And these are things which people can do on a regular basis. Even if you don't have lymphedema, what we advise patients to do is, if they've been operated, the arm on the operated side must be taken care of very carefully. The skin must be taken care of. Regular exercise. Don't put on weight, because that's another tendency of patients who've undergone breast cancer treatment because of the drugs and because they tend to eat. They're saying they eat healthy, so they tend to put on weight, and that weight triggers a lot of other side effects. So it can worsen lymphedema as well. So lymphedema care is a separate topic, very vast, and probably not a forum for this discussion, but I'll be happy to answer questions on this later. So what we did at Prameya is we identified certain unmet needs which have been poorly studied. Like I said, they are in 4 domains: the physical, the emotional, the physical, the emotional, the nutritional, and the spiritual domains. But whatever studies have been done so far are basically talking about the physical body image issues, fatigue, arm, shoulder movement, and so on. Then emotional, which is fear of recurrence, anxiety, depression, then relationship issues. And also, like Lopa said, taboos and cultural issues in India are too much. So we have people, women, especially in the north, who will not tell their family that they have a lump until it's too big. Because, in a joint family setup, they may be thrown out of home and their husbands would be asked to remarry and things like that. So those kind of taboos still exist. And probably with all the awareness campaigns that are happening, the kind of work that BCH is doing probably is opening up a lot of avenues for early detection. So coming to the survivorship phase. So treatment is over, everything is fine, and women are left in the lurch. Suddenly they find that they don't have to go and meet the doctor, they don't have hospital visits, and they find themselves a little insecure. So what will happen to me? How often do I need to go back for a checkup? How do I look after myself? You know, who's there with me to advise, and how do I know that the cancer won't come back? So looking after yourself is very, very important. So eating a healthy diet, paying attention to your nutrition, exercising well, being positive, you know, you're keeping your spirit up. Somebody was saying that, you know, that really helped them. So, and being part of support groups really helps. So we've been seeing in the, you know, from literature in the West and all those forums in US and UK that there are a lot of support groups. But those are very, very non-existent, I would say, in India. And only recently we've started this kind of a thing, and, you know, organizations where they can participate. And BCH has done a wonderful job of, drawing the supportive group together across nations. So I must congratulate Lopa at this juncture, because I've been part of this for the last few months, and I've been learning a lot. I've been really learning a lot from the interactions that are happening with the patients in the group. And of course, more importantly, we have to tell about follow-up care. In India, we don't have an organized screening. That's a problem. So nobody sends you a reminder like what Evey said today. Set it on your smartphone. That's very important. But nobody, the government or the health service, does not send you a reminder to get yourself a mammogram or an ultrasound. So follow-up care is very important, and that can happen via support groups. We can periodically remind people, have you had, you know, a pap smear? Have you had a breast self-examination? Have you had a clinical breast examination? Especially if you're a breast cancer patient, you must worry about other cancers, you must worry about the opposite breast, and you must worry about your family, especially if you're a BRCA1 or 2 positive. So these are things that can happen in the supportive care setup. And this is a picture of the program that we run. Again, Lopa, I have the permission of all of them to share these pictures. So it's a very multidisciplinary supportive care. All that has happened so far in India is probably restricted to one domain. It could just be something on exercise, or it could be just on emotional counseling. But what we are trying to bring together is a multidisciplinary supportive care of providing them the correct information, of allowing them to share their problems and, you know, concerns, of doing some supervised physical activity for them, emotional counseling through psycho-oncology, cognitive therapy, and, you know, helping them get rid of their brain fog post chemo, handling relationship issues, which is quite a concern, especially if we're having younger breast cancer patients. Then we have the wonderful yoga therapy that we can offer to them, the music and dance therapy. And also more and more we're talking to them about prostheses, wigs, lymphedema care. Because in India, as you know, they find all these things very, very expensive. So if we can make it more affordable and tell them that it matters, you know, body image matters, you must look good, it helps you feel better. So these are things which can happen as a very, very important part of breast cancer care, you know, not just surgery, chemotherapy, radiation, but beyond all of that. This is what, constitutes and helps them have a very good quality of life, because as we know, patients are living much longer now and almost near normal lifespan that they have. So I see a dawn of new hope. All of you, especially in India, awareness is improving. We are also doing things in our own small way. We hope it'll just snowball and the effect will be much higher. And we have better early detection. We have better treatment options. We have good care. So I see a very good community of people living with a very good quality of life. Thank you so much.
Thank you. Thank you so much, Dr. Sandhya, for all the insights, So thank you so much, Dr. Sandhya, for all the, you can all hear me, right? Yeah. So thank you so much for the insights, post-diagnosis and taking us through the journey of what to do next. And and amazing work Prameya is also doing. So hats off to you all. And a big shout out to our BCH support family. And, you all rock, whoever is here now. So a big shout out to you all, everyone. So we all are learning from each other. Yeah, thank you for being there. And everyone is welcome to our BCH family, of course, all the time. Our next speaker is, so as we have learned we have gone from early detection to diagnosis part, post-diagnosis part, and we are honored to have here Dr. Nilanjan Ghosh, our next speaker, MD, Ph.D. He is the chief of the Lymphoma Division, Department of Hematologic Oncology and Blood Disorders. He's also an associate director of clinical trials, Levine Cancer Institute, and also chief associate professor of medicine at UNC Chapel Hill School of Medicine. We are honored to have you, Dr. Nilanjan. Yes, the forum is all yours. Thank you.
Thank you, Lopa. It's been can you
Yes, we can
hear me? Okay. I hope there's not an echo. Yeah, so thank you so much for the invitation. So I'll spend a few minutes to talk a little bit about clinical trials and its role in development of new therapies. So as almost all the treatments we have now for not just breast cancer, for any cancer or for that matter, any disease, we've learned through basic science research, which then moves on to animal studies and then into humans. So that's the natural way of drug development or any other treatment development. So, I just want to walk you through the process of how that happens and how that applies to an individual who may be diagnosed. So how do you choose between existing standard treatments or clinical trials? So the first part is, whenever there is a new drug which is being developed, typically, there is some really work on human or animal cell lines and some animal models, and there they may see that there is an activity against a particular tumor. For example, when Herceptin was developed for breast cancer, right? It's an antibody against, or for that matter, other, small molecule inhibitors or chemotherapy drugs. They see that, okay, this is able to kill breast cancer cells, and then it's also able to kill breast cancer in animal models. Then they move this to humans, and the first study in humans is called a phase 1 study. I think a lot of people have heard about these phase 1, phase 2, and phase 3 in this COVID era, because you keep hearing the vaccines. Are they now in the phase 2 or are they in phase 3? Everybody's thinking that when will it come out, right? It's usually after phase 3. So what is phase 1 doing? So phase 1 is usually looking at a new drug and looking at the safety of the drug. Okay, is it safe to give it in humans? Now, of course, if someone is participating in a phase 1 study, their goal is not just to find the safety thing, but the inherent goal actually of phase 1 is to find safety and find the right dose. Now, as a secondary objective, obviously you want to have a treatment effect. That will it work or not? But before the phase 1 is done, it's not known. But a phase 1 is the first opportunity to have exposure to a new agent, which may make it big or it may not. But phase 1 will tell us that, okay, if this drug is safe and what is the dose of the drug which can be safely administered in humans. But they also look to see if there's some activity at the dose which were given or at the maximum tolerated dose, which did not cause too many dose limiting toxicities, also known as DLTs. Can we move this drug forward for improving the outcomes in a particular disease? Okay, so let's say a phase 1 study is done and they find that yes, at a dose which is safe, they were able to see some responses and there is some excitement to now move it forward. Then they move it to something called a phase 2 study. Sometimes in these days, they jump the gun and go straight to phase 3 if the phase 1 data looks pretty good. But let's say they go to a phase 2. So phase 2 is a larger study than a phase 1 study. And there they are looking not just at the safety, but a bigger experience on the safety, but they're also looking at the efficacy. Is the drug going to work? Is it going to help breast cancer patients shrink their tumors? And the basis would be, look, we did a phase 1, it's safe, and a few people had benefit, but we need to do a larger study to understand whether this is going to have more of an efficacy and then move into a phase 3 study or not. So phase 2 is sort of intermediate. In phase 2 results, if they're looking good, that okay, now we have 2 studies showing that we not only is it safe, but it's also now showing some activity, but we really need to test it against the standard treatment option. That's where they move into phase 3. So phase 3 is often a randomized study. So what does randomize mean? Randomize means that, you know, half the patients are going to get most likely a standard existing well-known treatment, okay? And the other half patients will get the standard treatment plus the drug. So sometimes in the standard arm, they will add a placebo. That does not mean, and this is very important, people always think that will they get, if they go on a cancer study, will they get a sugar pill? They might get a sugar pill, but this is not going to be a sugar pill versus, you know, something else. This will be sugar pill plus the existing treatment versus the new drug plus the existing treatment. They are not experimenting on someone and just giving them sugar pill. So the phase 3 study usually is taking people who would otherwise, if they didn't participate in the study, whatever would be the standard of care, plus either the new drug or just placebo. So in that study, they need to make sure that both groups are well matched. Because if one group has triple negative and the other one has ER/PR positive, then obviously the outcomes are going to be different. They need to make sure that the prognosis, the disease characteristics between the two groups are well matched so that they can definitively discuss the effect of the treatment on the outcomes rather than putting that on baseline poor or good prognostic markers. So they try to match the age, they try to match the number of prior treatments, they try to usually match the disease characteristics, equal number of good risk, poor risk, intermediate risk in age groups, and then they do an intervention. And by doing an intervention at that point, they see, are both groups getting same outcome? Is one group getting more inferior outcome? Is one group getting a better outcome? So this is a definitive study, and usually this leads to FDA approval if there is an improvement. So they do a predefined set of, we need to see a 20% improvement in arm A versus arm B. Let's say arm B is the standard arm. So now if there is an improvement and it meets the preset criteria, then the study is considered to be positive. And you may see things like progression-free survival or overall survival as endpoints in these studies compared to response rates as endpoints in phase 2 studies. And because ultimately what matters is people surviving longer and people surviving longer without disease. So that's progression-free survival is surviving without disease, and overall survival is overall life expectancy. So if they see that there is improvement in this with the experimental drug compared to the standard drug, now you've just created a new standard treatment. The next trial will probably take that new treatment as the standard arm and try to improve on that. That's how over decade, we've made so much progress, because every time a new standard is established and then a new drug come out and say, you know, we've done better, but we could still do so much better because we are not curing everyone yet. We want to get to a point where maximum number of people can be cured, or at least be functionally cured, meaning they may live with their disease, but still expect a normal life expectancy. Maybe the disease is not completely gone and they are much older, and they may, they don't suffer from the consequences of the disease. So that's really the goal, and we are far from that, but clinical trials is the way to go. So I want to end by trying to say, how do we choose, right? How do we choose whether a trial is fit for you or not? I think it's extremely important to have full transparencies about what is being given, what are the needs which are required from the patient perspective, that, you know, these are the things which are needed. It's a commitment, and it should be clear that they should not be biased. That they should really feel comfortable getting into it. It's also voluntary informed consent, which means that if you don't feel comfortable at some point, you can sign out, and you should still be able to get good standard treatment, and your doctor will not abandon you. So this is something which the patient and the doctor both need to be comfortable offering and sticking to. And it should not, there should be no coercion. Patients should feel that this is for their own betterment and maybe for betterment of the society as well. So I think it's a very, very important point. And then after that, also the commitment, because once they sign up for a clinical trial, there are scheduled visits at a scheduled number of time to make assessments. So making sure that they would be committed to that, so that they would really not be able to answer the questions which are trying to be answered. It is also an opportunity to get first-time exposure to new drug agents. So if you think and if you believe the background data, then you hope that maybe you would get a better response than what you would get with standard treatments, and you would be the first in the group to actually be exposed to a drug which might become the standard of care. There is also sometimes, just to level the amount of confidence, sometimes there needs to be equipoise at the time of enrollment. We cannot just assume that by getting a new drug, it's always going to be a winner. So the way to have that is to say that, okay, if it doesn't even work, at least you're getting the standard treatment. So I think those are very, very important things to understand. And you should really have enough comfort in mind. And a physician usually has to spend much more time, and along with the research nurses and research team, to talk to a patient about a clinical trial than to just do standard treatment. So it is very time consuming, but this is the way we get new treatments. This is the way we advance the field. So that is all I have to say. Sorry, I don't have any slides. I just wanted to just discuss a general perspective about this. And I really want to thank Lopa and Breast Cancer Hub for giving the opportunity, and best of luck. Thank you.
Thank you. Thank you so much, Dr. Nilanjan. That was really great, because we really wanted this flow, detection, then diagnosis, treatment, and then what next? The clinical trial is the next phase, and how to, what to expect and how to go about it. And thank you for giving your perspective, which is so valuable for each of us over here to learn from you. Thank you very much for your time today, Dr. Nilanjan. And our next speaker is Sharon. I'm going to just Sharon Rivera Sanchez. Sorry, Sharon, if I'm pronouncing it wrong. She is a breast cancer survivor and the founder and director of Saving Pennies for a Cure, which is a 501c3 nonprofit organization. And they advocate, educate, and empower cancer patients. And Sharon is going to talk about the clinical trials in the African American community as a follow-up on Dr. Nilanjan's talk today. Thank you, Sharon. If you would like to unmute yourself, please. Thank you.
Okay, good morning. You can hear me?
Yes, perfect.
Okay, thank you for welcoming me, and thank you for having me. It's a great panel, and I'm happy to discuss perspective on clinical trial in the African American community, as well as my own experience as well. In the African American community, we have a problem with trusting. We have a problem with clinical trials not being in our neighborhood or near us. And because of that, we only have 5% that actually participate in clinical trials. We also have a problem with doctors, physicians just mention clinical trial to us. So here at Saving Pennies, we're trying to change that. So we can try to get more people to participate in clinical trials. And now it's a great time because with Corona, a lot of things are being local. Like, for example, I'm in a clinical trial at University of Pennsylvania. That is 4 hours away from my home. Well, my last visit, we did telemed, but my labs was done here. And I was so excited that I did not have to travel 4 hours. But things are changing. When we look at, I first want to discuss the positive part of a clinical trial. I did not get enroll in a clinical trial until after I finished all my treatment. And I am a triple negative survivor and thriver. So it's very hard to treat triple negative. We don't have a lot of drugs, as you heard earlier. So I was watching Good Morning America, and they started talking about clinical trials. And this particular clinical trial that I first got in was in California. I'm in Richmond, Virginia. So California is about 3,000 miles away from me one way. So round trip about 6,000 miles. So I had to think outside the box and figure out how was I going to get to California, because I actually had to travel to California, and we made it work. I was scheduled to travel to California every 90 days. And that trial was going to transfer over to Sloan Kettering, which is in New York, and that didn't happen. So going to California every 90 days for 2 years was not going to work, but I was committed to get into a clinical trial. And I found the one at University of Pennsylvania, and I've been in that now for 2 years. One of the benefits it's many benefits of clinical trial. Number one, you heard the doctor say you have access to new drugs. You are regularly checked by physician. So once you finish treatment, you sit there and you like, what is next? Because you are terrified that it may come back or whatever. Any little ache, you think, oh, my cancer have returned. So you not only are monitored by your regular doctor, you monitor also by the clinical trial staff as well. So that's one of the benefits. Like I said earlier, access to new drugs. It's not, I don't want to mislead anyone and think that clinical trial is going to prevent a reoccurrence or anything like that, because that's not what they for. They test in new drugs. Scientists are learning. So if you want to be a part of this, most people get into clinical trials because they're afraid it's going to come back or it has advanced. You just want to make a difference. I mean, cancer is awful. It's not anything you wish on anyone. So this is another way that you can make a difference. With the African American community, with the distrust, you hear about Harry Truman, you ask, what do you know? And most people cannot tell you. So what I would say to physicians is you have to earn that trust. When you meet someone, be honest, if you ask them about it, ask them, is it a problem with distrusting, and discuss that with them. I can tell you that I have physicians right now, if I don't normally email them on a Sunday. I have that level of respect, but let's say if it was something that I email my study team with, I can guarantee they will email me back. If something's going on, someone will email me back. That's part of earning trust. If you make an appointment with someone, if sometimes things come up where you do have to cancel, but you don't do that on a regular basis. So I would say with the African American community, the first thing you will have to do is address that, and then you learn to earn that trust. Is many studies that's out here that's going on right now. And just like I said, this is the best time to get in a study. When we look at chemo, we know, and I'm not a physician, so I'm not speaking for a physician, but with triple negative, that's what we have. We have the chemotherapy, but now I can't think of the name of the study where they was testing now they can test your tumor to see if you have to have chemotherapy. Without research, we wouldn't know that. We would still be where we at. So, we look at pills for nausea. All that comes from research. And it's great that we test the animals, but we need humans to test as well. Black breast tissue is different than our counterpart. So if we come out with a study and say that worked, for us, you know, African American, if we only had 5% in that study, we can't really say that that worked for us. So we definitely need to try to increase our presence in study. We have 42% higher mortality rate than our counterparts. So all that plays into factor. So we just trying to really get out here and get the word out in as many types of clinical trials. Some you do take medication, some you do not. I mean, you have clinical trials going on right here where I'm at in Richmond involving exercise. You're looking at obesity, different things. So you definitely can make a difference. With radiation, a lot of times you hear about the burning skin. Well, that's not the type of radiation I had. I had radiation even with triple negative. I had radiation 5 days a week, twice a week. Love it. I had partial radiation. So I cannot relate to the skin peeling and the burning. But I can tell you it's a study going on called RATCON, and that's different centers where they are looking at proton, they're looking at the difference in radiation, trying to make a difference there. When you look at for as patients, how do I enroll into a clinical trial? We are trying to get the physicians to make sure that they mention clinical trials. I know here in Richmond, they're going to start wearing a button asking on their coat to say, ask me about a clinical trial. At least that will start the conversation. I will say you have to watch how you position a clinical trials to physician. Diagnosing a patient with cancer and mention a clinical trial should not go in the same sentence at all, never, because they first have to, adjust to this. What I'm being told, I have cancer. So you're going to lose them immediately if you put that in the same sentence. But we have this clinical trial. Okay, that should not go that same day. So you have to watch how you position that. They have the government sites, clinicaltrial.gov. Personally, for me, that for a patient that could be overwhelming because they don't know what they're looking for. So you have to kind of guide them. If your center don't have a clinical trial that you feel that they could fit in, I would definitely like to mention Clara Health. It's an easy site. They help you find your clinical trial. Again, I found mine on my own both times. So it's just, those are some of the things that I would just like to mention. But clinical trials are definitely a good thing. And I don't have any slides to share that with you. I'm a 5-year survivor, and I would not hesitate to answer questions and take questions, but encourage not only the African American community, but everyone to join force and get into a clinical trial.
Thank you. Thank you so much, Sharon, for advocating for clinical trial. Being a scientist and working with all the trials myself, I know how important, to increase the number of candidates signing up, but definitely we have to be transparent with the pros and cons so that everyone we discuss, and as Dr. Nilanjan and you mentioned. So thank you for the insightful talk. And now we are going to take you to our next amazing speaker, Dr. Raghava Reddy Induru, who is an oncology specialist, medical oncology, hematology, and also a palliative care medicine specialist from Levine Cancer Institute, who is going to walk us through a little bit on the metastatic breast cancer and take us to the forum of palliative care, which is so important. And then next will be coming Mrs. Durgaji, and so which will be a follow-up on what you're going to hear from Dr. Induru. So we have our next last two speakers coming up, and very critical speakers on our forum. Thank you so much.
Thank you, Lopa, and thank you for organizing the seminar in this special month of the year. As well as, I think, a really big thank you for all the audience that have taken their precious time to listen to this talk. So without overdue, and in the interest of time, I will try to keep relatively brief so to make sure that we have some time for questions. I'm covering a topic that we don't want to see. As a medical oncologist, if I take care of someone with metastatic breast cancer, we do certainly feel, or it's heartbreaking that it should not have happened, or we wish we could have done a better job. So, but in the current scenario, there are at least a significant amount of advances that are able to be provided to the patients with metastatic breast cancer. So, as Dr. Sandhya covered early breast cancer that is metastatic is defined as what we call a stage 4 breast cancer. Breast cancer can, or any cancer can spread certainly in two different ways, through the lymphatic system and through the blood system. So we imagine that like as two different roads in our body. Breast cancer, unfortunately, does not spare any organ. It can go from the other breast to bones, to liver, to pelvis, to skin, to brain. So it really exemplifies the importance of early detection and prevention because it doesn't spare any body or any part of the body. The prognosis depends on several factors, but unfortunately, once the metastatic breast cancer is diagnosed or found, it is considered incurable. The prognosis is defined by survival. The survival can range from 2 years. That depends on various factors. Although over the last decades, we have made significant advances that the survival has improved significantly over time, but still it is considered an incurable stage. Typically, when we take cancer, the incidence or the percentage of breast cancer patients of anywhere between 5 to 10% of the breast cancer as stage 4. Again, I'm stating the statistics in the United States. India, certainly that percentage is much higher, but gradually coming down. Diagnosed early stage breast cancer can progress on to metastatic breast cancer. That can happen in about 20 to 30% of the cases that we take care of. So the goals of treating a metastatic breast cancer do change based on clinical factors, meaning about the individual. Someone who is 45 years old might have a different goal of care than someone who is 85 years old. So there are several factors we keep in mind as we do treatment plan. Of course, the cancer-related factors, ranging from the biology of the cancer. There are signals that give us an ability to use targeted therapies, as well as the tumor burden, how extensive the cancer is. Is it causing? Is it involving the liver? Is it not involving the liver? So there are several factors that play into the design of the treatment itself. Focusing on the treatment, as a physician, I'm only a small piece of the puzzle. We depend on multiple resources to be able to take care of it. As the wheel, as depicted in the wheel picture there, the treatment depends on multidisciplinary approach as well as a multi-modality therapy. There are several folks who are involved in this, ranging from nurse navigators to case managers to nutritionists to therapists to the pathologists, radiation oncologists, clinical trial coordinators to, I can just go on the list. There's so many folks who are involved, and the patient is the central part of that wheel. There are multiple modality of treatments we use as well, ranging from surgery to radiations to, I call them more of medical therapies these days as opposed to chemotherapy, because there's a lot more treatments that we have now that we did not have before, as well as supportive care, which is really becoming the key component of taking care of anyone with this for breast cancer. From a medical therapist standpoint, I usually divide them into three major categories. I generally define that as something like a bomb. Like it has a space, but it has the ability to cause a lot of collateral damage. That collateral damage from causing nausea, vomiting, to losing hair, having GI or the gastrointestinal toxicities, emotional, as well as affecting and interacting with the other medications and medical comorbidities this person has. The older the person is, the risk of toxicities from chemotherapy. So as a medical oncologist, I generally termed as chemotherapy doctors, we don't enjoy giving chemo. We never enthusiastic or get excited about ordering a chemotherapy regimen or treating someone with chemotherapy. And on any given day, we try our best to not administer chemotherapy. We try as much as possible to minimize the toxicities of chemotherapy. Chemotherapy can be used as a single drug, multiple drugs, can come in different regimens like weekly, every 3 weeks, every 4 weeks. So there's many different ways. Chemotherapies tend to work directly on the cancer cells, but it can also there are normal cells like blood cells, hair cells, skin cells, etc. Then of the medical therapies are targeted therapies. Targeted therapies, I view them as more like the guided missiles. That means we need to have a target to be able to target that. Therapies are specifically targeting the hormone signals. HER2 directed therapy, as Sandhya has alluded them, like for example, Herceptin. It has literally revolutionized the treatment of some of the parts of the breast cancer. There are lots of targeted therapy approaches. So every year we're able to identify new targets and that's where the clinical trials really play a big role, because without clinical trials, we're not able to bring these targeted therapies into the main standard of care. There are lots of treatments that we use along with medical therapies. Palliative radiation, someone who has pain to a place where there is a spot in the bone. There are liver-directed therapies, although they're not the standard of care yet, but there's more and more we are learning where using chemo beads or radiation beads to try to directly target the cancer in the liver. Bone agents, someone with bone metastasis, where they can be vulnerable to fracture. We could provide some agents that could help decrease the risk of any This picture kind of gives us a sense of what are all the targets we can look at. Very small information that we know as of 20. There's much more to unravel. So there are some of them, like ER means estrogen receptor. Okay, these are called tyrosine kinase receptors. PI3K, MTOR, CDK4. So these are different signals that helps the cancers multiply, spread, and escape our immune system. So targeting these agents or targeting these signals as to control the cancer. How do we monitor? Typically through a history and physical exam. There are some blood tests that we use, something called tumor markers. There's something called imaging studies where we use PET scans, CT scans, MRIs in different ways depending on the symptoms. There's some new advancements in something called circulating tumor cells, which could be the future of how we monitor therapies as well. Not the mainframe yet, but the future. What does the future look like? I think the future is exactly in the picture I've put in there. It's a very complicated picture, but you have a sense of where the research, without the researchers, without the bench researchers, the clinical trials, I don't think we can make much into identifying what targets we can target next. Prevention or detection really becomes the key, because we want to see a time when I don't see a stage 4 breast cancer. A brief word on palliative care. So myself, certainly I had the privilege of being trained both in palliative care and in medical oncology. I may not practice palliative care full time, but I use the principles that I learned in palliative care in my everyday practice. So what is really palliative care? So palliate means to relieve the symptoms. So palliative care is an integrative or an integrated multidisciplinary approach to take care of symptoms that comes with it, because cancer is a very, very complex process. It is very distinct from hospice. Palliative care is not hospice. Hospice is typically employed in the end of life. Palliative care can be an early starter. It can be something that can be incorporated in the treatment of any cancer. How does it work? It involves a team. It involves a team of people who can help with the symptom management, both psychological, somatic. Somatic means physical symptoms, as well as emotional symptoms. A palliative care team includes a huge number of people: nutritionists, physical therapists, counselors, social workers, bereavement counselors. So there's a whole team there. What is the evidence? There is more and more evidence coming up now where the early incorporation of palliative care seems to improve the quality of life, as well as actually improve the survival of patients with advanced cancer. What does the future hold? Actually, I want to see palliative care involved more and more early in the disease trajectory. I think this slide absolutely explains where we were, where we're going. A traditional palliative care over the last several years started when we stopped offering medical therapies for advanced cancer. But where we're going, or where we're actually already started our foot, is where involving the palliative care much early in the disease trajectory, as the symptoms and the goals of the treatment change as we go along. So that's where we want to see. I think I would stop there. I'd be happy to take questions at any time. I would pass the microphone to Durgaji.
Yes. Thank you so much, Dr. Raghava, for bringing the metastatic breast cancer into the picture with the palliative care insights, because there's always a perception that palliative care means at the end. But to bring this up from the beginning, that's really important for all of us to know, for everyone to know. And I have been advocating for palliative care all throughout, especially in India, where we do not see much of it, even at any phase, kind of because people don't even speak about it. So it becomes a very different scenario. But thank you for bringing this up. And our next speaker is amazing. She is an integral part of our Breast Cancer Hub support family. And Mrs. Durga Gopal from Hyderabad, metastatic breast cancer survivor and author of 2 books, My Rendezvous with Cancer and Cancer and Doctor's Perspective. Thank you, Mrs. Durga Gopal, for your time today. We are honored to have you here. Over to you.
Thank you, Lopa. Can you hear me, no?
Yes, I can hear you. I can hear you.
Thank you, Lopa, for including me in this forum. Well, I'm Durga Gopal and I'm stationed in Hyderabad, India. I'm a stage 4 cancer patient, breast cancer metastatic. Well, today I would just like to give you a small brief history about my journey through cancer. I had cancer twice. My first bout with cancer was in the year 2010 when I was in Delhi. They found a small lump in my right breast, which later turned out to be malignant. And so I had lumpectomy done and I had radiation for about a month. Then I had treatment for about 6 years, and after 6 years, I was declared cancer-free. In the year 2017, I went to US to be with my son and daughter-in-law for 5 months, and then I was for 3 months with my daughter in Germany, and I returned to Delhi in November 2017. When again, to my dismay, I found that I had a big lump on the left side above the breast, and so the cancer returned with a bang. The doctors also found that part of the cancer had spread to the lungs, to the lymph node in the lungs. So it was stage 4. So then I had decided to shift from Delhi to Hyderabad because I had the support of my brother there. When I reached Hyderabad, I was directed to a hospital called Omega Hospital, where I met my oncologist, a wonderful doctor, Dr. Dattatri. At the outset, he told me that I have to take a few chemotherapy cycles, and along with that, I had to take 2 maintenance medicines, Herceptin and Perjeta. And these maintenance medicines were to be taken lifelong. every 21 days because it is stage 4. These medicines were exorbitantly costly. So every cycle I had to spend something like 3,50,000 every 21 days. So in order to tide over this high medical bills, I had to sell my house in Delhi. So the first year of my stay in Hyderabad, I spent something like about 60 lakhs. Now also every year I spend something like 10 lakhs. I reached Hyderabad in the November 2017, and by January 2018, within 2 months, the cancer in the lungs had disappeared, and in another 5 months, the lump also disappeared. So I had my mastectomy done in July 2018. From then on, I'm on these 2 maintenance medicines. Every 21 days, I get admitted to the hospital, and these medicines are injected into my body. So today I'm going to tell you more about, I've not gone more into the morbid details about the disease. I'm going to tell you more about how I am dealing with this problem after my surgery. Now, once during my chemotherapy sessions, when my oncologist came to meet me, I showed him a poem called Hope. I told him that he could show it to some of his cancer patients. And it's written by a patient who really doesn't have any hope because we are stage 4. So he liked the poem a lot, and he told me that, "Madam, why don't you write a book, Your Journey Through Cancer?" So that sowed the seeds for my first book, My Rendezvous with Cancer. This book was a pure and a candid narrative, giving glimpses of the first reactions and the trauma that a cancer patient goes through when confronted with this kind of deadly disease. The book received very good reviews, and my oncologist had the first and the last page and the middle page of the book framed, and he has hung it in his consultation room where it still stands today. So my book could not have got a better tribute than that. Now, last year, my oncologist gave me the privilege of working in his OPD as his assistant. I go to the hospital Monday to Friday, and I meet all the cancer patients, all his inpatients. I find out their woes and their problems and carry his grievances to him. Whenever I find a patient who's dejected or desperate with the disease, I try to instill in them a hope and a confidence that if they take this with a positive attitude, no disease can stay in their body for long. Many of my patients tell me that when they see me, running around the hospital with this kind of vitality and enthusiasm, they say that it gives them a lot of hope and their confidence. In fact, many of them mistake me for a doctor. Only a white coat and a stethoscope are missing. The stage 4 cancer has been a turning point in my life. It has taught me the value of life, the sanctity of death, to appreciate my relationships, and above all, to count my blessings. After the success of my first book, people encouraged me to write a second book, Cancer: A Doctor's Perspective. Now, the first book had only real life incidents, so it touched the reader's heart. So in order to incorporate such real life incidents, I approached my oncologist, and through him, I met some of his patients. Believe me, it was an eye-opener for me. I realized that what I had gone through was absolutely nothing compared to the trauma these people are going through. These people I find were real heroes, people who may not have battled at the war front, but people who have battled with life vigorously, ferociously, and emerged as winners. So, of course, this attitude I find in almost all the people in the breast cancer hub. Very often, I feel that cancer has been a blessing in my life. If I had not got stage 4 cancer, I would not have shifted from Delhi to Hyderabad. I would not have met my oncologist, and I would not have known that I could write. The success of my book had left me in a euphoria for a very long time. My doctor also gave me a direction in my life, a life that was self-centered and cluttered with my children, my home, my career. Now the my has turned into ours. I help the cancer patients morally, emotionally, and financially. With the help of my oncologist, every month we try to identify one patient and I transfer a part amount of, as it is also, I have to undergo a lot of heavy medical expenses. So I try to give a small amount of from my finances so that they can tide over a part of their financial deficit. I have written my will in such a way that after my demise, a fixed amount will be given to the needy patients so that they can at least cover part of their medical expenses. I'm hopeful that this arrangement will carry on for a period of 10 to 12 years after my demise. I have also made arrangements for the donation of my body parts immediately after my death. I know what I'm doing is nothing great. It is just like a speck of sand on the beach. I cannot give the patients the kind of physical help which the doctors are giving, but I try to instill in them a hope and a positivity to address their ailments so that they can embrace life once again. A patient needs both physical help and mental help. Well, I try to give them the latter. I tell them the gist of life in 3 sentences. Live life as it comes. Don't worry about the tomorrow. Today is what that matters. It is ironical that a disease like cancer, which has been termed as the emperor of catastrophes, and the very name sends a chill down your spine and puts you into bouts of dejection and depression, has given me back my smile and my laughter. When you're confronted with a life-threatening disease like cancer, and you know that your days, months, or years are numbered, you have 2 ways to live your life. Either you cry, you curse your fate, your God, or you think that this is a second opportunity given by God so that a second innings so that you can make your life more useful by helping humanity and rendering as much help as possible. I chose the second way. I go to my hospital Monday to Friday, and on Saturday, I go to a palliative care institute called Sparsh Hospice. Because they've already told you what's palliative care. So this, whenever cancer patients are told by the doctors or by the hospitals that they have no further treatment to undergo, so these people are at a cul-de-sac, and so they don't know where to go. At this time, Sparsh Hospice opens their doors for them. They provide free food, free accommodation, and free medical care, and also take part of all their entertainment and try to fulfill their unfulfilled desires. And I'm really proud to be associated with such an institution that works for such a noble cause. Before I conclude, I just want to say this. For us cancer patients, our obituary note is already written well in advance. Only the date is not specified. Some of the doctors have told me time and again that you are stage 4 and this cancer will come back. But I tell them no, I'll die of something else other than cancer. So let us see whose side God will take. I keep telling my friends and relatives that after my demise, if they remember me even for a fraction of a second, they should always remember me as a lady who was perpetually young, who was bubbling with life, and knowing fully well that death was at her doorstep. Never let the smile leave her lip. Thank you.
Thank you. Thank you so much, Durgaji. I mean, I'm fumbling with words. I don't know what to say after hearing you. And can only say this much, that we are here with you and you are giving everyone hope, and you are an inspiration and motivation for all of us. And I think with, for each cancer patient, for each survivor, it's a learning that we all need to learn from, from each of you here, from Evey, from Sharon, from Durgaji, all the survivors in the panel. And thank you to Dr. Sandhya, Dr. Raghava, Dr. Nilanjan for bringing all these perspectives together, and for enlightening each of our guests here with so much of information and such an inspirational journey, Durgaji. And we are so thankful to have each of you here. We are honored to have you here. So saying that, I would definitely, like to take a lot of, there are questions on the chat room coming up. And we will try to go one at a time. And I think the first question over here, as I can see, is from Sohini Chakraborty for Dr. Nilanjan. And Dr. Nilanjan, the question is for you. As we know, the phase 1 of clinical trials involve healthy individuals. What is the scenario regarding cancer trials? Do healthy individuals volunteer in trials for anti-cancer drugs? And the second question is, what is the washout period for the IP used in the trial in case of cancer trials? So Dr. Nilanjan, if you would like to unmute yourself. I don't know if Dr. Nilanjan is still here. Or Dr. Raghava, would you, or Dr. Sandhya, would you like to take this? But I can take the first question. So Sohini, because I'm a scientist reviewer for Department of Defense Breast Cancer Research Program and for the clinical trial phases. And definitely we are not enrolling healthy individuals in there. So Dr. Raghava and Dr. Sandhya can chime in, please.
Yeah, regarding, this is Sandhya here, Lopa.
Yes.
Regarding the, yeah, we don't, I have worked in clinical trials. I was heading a CRO in India, for some years. And we do healthy, we enroll healthy volunteers only for non-cancer clinical trials. And the washout period for the IP use in the case of cancer clinical trials, it depends on the drug, the pharmacokinetics of the drug, how long it takes to be metabolized by the body. So it varies from drug to drug. And typical washout would be, where we do use a 3-week period so that the blood parameters and all of that, supposing the patient is already on other medication, then the blood parameters, if they are affected by those, say the liver function tests and so on, can come back to normal. That is what we do in the healthy individuals. But in the case of cancer clinical trials, we take into account what we call the pharmacokinetics of the drug. So how long it takes for the drug to be eliminated from the body. And then we, if it is a crossover study, for instance, what we take into consideration. I hope that answers your question.
Absolutely, absolutely. And Dr. Raghava, do you have anything to add, or we are good?
Yeah.
Okay.
No, I echo Dr. Sandhya. And typically, even for phase 1 studies, there are no healthy volunteers. It's usually you have very limited treatment options, and phase 1 is a way to get the new drug to understand both the dose, whether it's effective, and running a phase 1 clinical trials are quite a task, but I think certainly a lot of places are blessed with these trials.
Yeah, absolutely. And also we always, Sohini, we always make sure, as reviewers, that we check on the toxicity of the drug. That becomes like a first and foremost important aspect whenever we run any clinical trial with all the phases. So the next question is, I don't have the name here, but the question is, today it was briefly touched upon the surgical procedures that are less reconstructive and more conservative of breast tissue are actually more beneficial for tackling breast cancer. With my limited knowledge of the subject, I remember that there was a time where more invasive procedures such as single and double mastectomies were used to prevent relapse or recurrence of cancer. What is leading to this change in ideology? What is the reasoning behind engaging in less invasive procedures? So I think, Doctor, yes, so we tried to touch base on everything, whatever, because cancer is a vast subject, but we wanted to bring into limelight the importance, the current scenario globally going on. So that was the motive for this seminar session. But Dr. Sandhya has touched base a little bit on it, but Dr. Sandhya, you can definitely answer. And then later on, if anything, then I can chime in like from the scientific perspective.
So it's all to do with the biology of the disease and our understanding of the biology of the disease. So in the Halstedian area, Halsted was the pioneer for radical mastectomy. So where breast cancer was thought to move very systematically from the breast to the axillary lymph nodes, then to the supraclavicular. So they thought that removing that entire area could cure a patient of disease. Then they found out that even though a person who had a very small lump did not do well from such a major operation, So now there is a lot of evidence, there are a lot of clinical trials which have shown that if you do the results of a breast conserving surgery where you preserve the breast versus, for the same tumor condition, same stage of the disease, if you do a mastectomy versus a breast conservation, the results are the same. So there are certain, things which we take into account in deciding whether a person is a candidate for breast conservation or for mastectomy. So we have the option of doing less to get the same results. And that is based on the biology of the disease and our understanding of it now. We know more, like Dr. Who spoke about the metastatic breast cancer, and
Dr. Raghava. Yeah,
Dr. Raghava. He told us that there are a lot of markers that we use, and we've learned a lot more about the different stages at which the cells undergo change. We know the targets. We know all those things where the disease actually begins. So that the targeted therapies are coming into play now. And therefore, we don't have to resort to more radical surgeries and, more invasive procedures.
yes, perfect. Thank you so much, Dr. Sandhya. And I don't have the name who has this question, but I hope we could answer your question. And thank you for the question for sure. So one question I have is, how old was the youngest person you have helped identify? This is a private question. Unfortunately, that was a late detection. So it was in a remote village, and I can't disclose the name. And she actually inspired me to understand that, like how important at the age of 18 also. And that's when, before even till I went to the villages in India last year, till 2018, I was advocating for the age of 20 plus for breast self exam. But she changed my perspective, and now I'm saying 17, 18, earlier, just do your breast self exam when you know that you have developed a breast. And she is my inspiration. And we couldn't detect her early, but we definitely, with this protocol, we can save other lives. And that's the agenda, that's the motive. So thank you for asking this question, Hannah. So our next question is from Kalpita. How well is the psychological aspect, self-report questions, embedded in Indian medical system alongside diagnosis and treatment? Do we know about clinical depression association with the patients across stages? So I think maybe that would, again, because Dr. Sandhya and Durgaji are from India right now, they are talking from there. So would you like to mention that? And I can also talk to you, Kalpita, about this, because I have been traveling and most of the outreaches are in India. But definitely I would like to hear from Dr. Sandhya.
Yeah, so psycho-oncology is a fairly new concept here in India. And even oncologists resist, the fact that a patient could go through a psycho-oncologist before actually treatment begins. And there are hospitals which have a very good psycho-oncology department now in India, and we have psycho-oncology trained psychologists. And many hospitals incorporate that as part of, it's mostly in the corporate hospital setting. It's not happened in the government hospitals because of lack of time, the number of patients. See, in India, we have this huge patient load. So, we can't spend time, referring them for psycho-oncology consultation. Are you able to hear me, Durga, or is it fragmented?
No, we can hear you, Dr. Sandhya. And the question was asked by Dr. Kalpita.
Okay.
Yes. Yeah.
Okay, fine. But it is picking up, and a lot of hospitals are incorporating it into it. We follow the NCCN guidelines. So the distress determination, we use that distress thermometer as for initial evaluation. So we do have evaluation of the emotional component, the psychological aspects before treatment begins, and also during treatment.
Yeah. Thank you, Dr. Sandhya. And I just want to touch base here, Kalpita, over here that, I'll just tell you one incident. Like when I go to India, I try to penetrate I go to the houses and do the interviews in the local languages for the cancer patients, survivors. And then one of the women told me that, Lopa, you are the first one coming and asking me how you are doing. And you're telling me that my story is going to inspire others, how much I went through emotionally, and I couldn't share it with anyone. And no one even asked me even today that how did you overcome this? So this is like, it is so sad, but I think things are changing because a lot of things are changing in India. And but this is not one instance, Dr. Kalpita. This is like a replica wherever I'm like 80% of the situation I handled, I have seen this. But I'm so grateful that these questions are now coming up, the psychological impact, even speaking, discussing these things help, and to boost the morality, that's so important. So yes, definitely we are from Breast Cancer Hub. That's another more mission, we are working towards it. And thank you to all the oncologists for equally, and the supporters, like Durga ji, then Evey, Sharon, from each part of wherever we are globally, they are trying their best, to take it forward and help the other patients. So our next question.
Lopa, if I may
Yes,
add
yes,
one other comment.
absolutely, Dr. Raghava, yes.
Yes. So the prevalence of depression in cancer patients is unfortunately not so well documented. There are wide array of studies, and the incidence seems to be ranging anywhere between 20% to 50%, not having a clear understanding of how we should screen. As much as we use the NCCN distress screen, but I don't believe using it as effectively as we should, partly because there are time points at which the depression seems more prevalent than certain time points. But one thing that is really encouraging is the newer clinical trials are considering the patient-reported quality of life as one of the endpoints, what we call a secondary endpoints, where they take what the patients are reporting, not necessarily just the nausea, vomiting, or the additional side effects, but even the psychosocial aspects of so I think that is really, really an encouraging part of the new trials.
Thank you.
Thank you.
I just wanted to add a note that since we try to do research on stress and immune system, and we have shown that when having stress or stress-like symptoms, your immune system doesn't function very well. And especially with the chemotherapy outcomes, we have seen that if you have more social support, you actually perform better to chemotherapy outcomes. So that's why I was asking, especially in India, that we have a lot of patient burden, I'm aware, and people cannot really collaborate across. We don't have such a great culture of collaboration between bench scientists and doctors. So it is a great platform to bring that in through the forum like this, that it's actually needed to collaborate across, bench to bedside and translational, because there's a lot of information missing while it reaches the patient, and we don't really understand that. So yeah, thank you very much for all of you to answer my questions. Thank you.
Thank you, Dr. Kalpita, for bringing this up. And if any time, any of our speakers would like to chime in, please unmute yourself and do that, to answer the questions. You're most welcome to do that. So,
yeah. I'm sorry.
You have a question?
No, I just had a comment because, I went through cancer. I'm a physician myself also. Mm-hmm. And I thought that I think in the Indian culture, no matter how educated, I don't know if this is, the lack of emotional support is very high. I think there's just this feeling of, well, it's only small, or there's treatment and you can deal with it. And I am a pediatrician here in the US for the last 36 years. And the level of support, unfortunately, I feel is much higher with middle-class patients who support each other. The wealthy just, I don't know, they just don't. And the poor are just struggling with life. And I think in the Indian, I went through this and I was very fortunate. I was early, but I don't think, I have some great friends who helped me a lot, but even with family, I mean, they were there, but truly did not understand what you are, because you've been a professional, you've taken care of your life, you think you have your life in order. What do you lack? You're getting treatment. And the whole message out there is breast cancer is so treatable, but it did something to my head that I cannot even explain to you. It was so frightening. Although it was a stage 1, I was grateful, but the fact that I was stage 1 almost made other people complacent about, oh, it's no big deal. It was extremely frightening. So I think a forum like yours, or I've met Durga, she's wonderful, and I have great friends, but just to understand how frightening it is. And similarly, this thing about minimal surgery, well, I'm going to share this. I had a bilateral mastectomy in spite of a stage 1. For me to go and sit there every 6 months and have an MRI and deal with what I had gone through by myself almost was so frightening that I just felt like I want this out. I mean, it's a personal thing. It's not, but thank you.
No, thank you so much, Dr. Ratna. That's so insightful, because it's every person, it's like, as you know, every person's response is also different, and also that what they want to choose as a treatment. And it's so greatly said that something in the mind, it happens and no one recognizes that. And so difficult. And I see that in the culture, there's a lot of culture going on, and I think we are breaking it, and we will get there one day. So thank you for your insights. And our next question is from Vaishali Ghosh. This is probably like, if we remove the affected breast region, then why the patients die due to this very disease, even if the cancer is in stage 2? So Dr. Sandhya, would you like to answer this, or Dr. Raghava, or else? Yeah.
Yes. I mean, yeah, I can certainly shine, as well as, of course, Dr. Sandhya can add in as well. So irrespective of the stage, I think we really start understanding how the cancer works, how it spreads, or how it behaves in the body. If I really have to use a language that is understandable, I describe that as mostly, typically, if we imagine a 1 centimeter mass, that could, let's call it a mass. There is expected to be about 1 billion cells in there. So when you look at at such a high number of cells in a small sizable mass, it is believed that the cancer cells spread or could have spread even before we ever found it. That's why the earlier the detection, the lesser the chances it would have spread out. So even though the local treatments, which is surgery and radiation or a combination of both, are extremely important, but systemic therapies also play an equally important role to decrease that risk. The systemic therapies typically treat the cancers in a certain stage of that cancer cell, like what we call a mitotic. It means when the cancer cells are dividing. But if the cancer cells are dormant, or I call it when they're quiet, when they have a little shell over them, the treatments, the systemic therapies that we give don't tend to be very effective. And that's the reason why we tend to give the hormonal therapy for 5 years. And we always have that education about the risk of cancer coming back and how we have to manage when it comes back. I think that's basic an explanation we can think of, while we can go in on a scientific path in a much more comprehensive way. Yeah. Thank you.
Thank you so much, Dr. Raghava. And also, Vaishali, like if one cancer cell also is going and sitting somewhere else, it's very difficult to identify when we are doing the local surgery or taking out that tissue. So that's why, as Dr. Raghava mentioned, that, the earlier is better, but chemotherapy, that kind of takes care even with the earlier detection at stage 1, stage 2, right, Dr. Raghava?
And there is a really interesting advancement going on, but of course, I think it's going to be before we could have that as prime time, is the possibility of evaluating the risk of it coming back through something called circulating tumor cells. We're still in the very primitive stages of that research, understanding what does the circulating tumor cells means the cancer cells that are circulating in the blood, or the tumor DNA that is circulating in the blood. There's a lot of research going on. I think that is the future of able to identify the risk of something coming back through just a blood test and not necessarily the scans. Identifying in the blood predates the identification of anything coming back on the scan. So I think that's where we are heading. We have a few years to go, but certainly a significant improvement. Thank you.
And I would just like to say one thing on one of the clinical trials that I was on, they would go into your bone marrow and do blood tests. They would actually draw from that. And I was diagnosed with stage 2B, and they definitely found dormant cells. So that's what they was looking at. So cells, in my case, cells was hiding, and they offered me additional chemotherapy. They did not guarantee that, they could kill the cells, but that's something, I would just piggyback and say, yes, that is definitely something that they are looking at. So had I not did the clinical trial, I still could be going along not knowing that I do have dormant cells.
Yes, that's a
And having said that, I just want to make one point of the body's innate immunity. So we are beginning to understand a lot about that with the research that's going on in the triple negative breast cancer area, where we are seeing that the tumor microenvironment and the tumor infiltrating immune cells play a very major role in how that's going to behave. So, we can't kind of understate the body's immune cancer on its own, along with whatever treatment that we are giving. There's a major role that the immune system also plays there.
Yes, absolutely. Thank you. And I think a lot of my work I used to do with tumor infiltrating lymphocytes. So that also targeting those. So everything kind of is a cumulative way it's taking action. So I think, Hannah, I think we have answered your question in this too. Like, why does the cancer that starts in the breast spread to the other organ in the body? So that's what Dr. Raghava had explained. But anything you want to add, Dr. Raghava, here? Or we are good? So the question is, why does the cancer that start in the breast spread to the other organs in the body? So why does it metastasize, basically, she's asking.
So any cancer can metastasize, whether breast cancer so there's no cancer that is not bound to metastasis. The way I look at that is, cancer is not something that comes from outside. Cancer is something that forms in our own body, because every day of our life, from the time we are born until the day we have constant injury to our cells, as well as our cells old, they die, the new cells come up. This is a natural part of each cell. But one time when these cells, when the new cells are coming up, and there is a problem with the cell, typically our body has something called checkpoints, where a cell is not fit for doing its job, it tends to discard the cell. But there may be a point where one cell becomes what I call it a rogue cell that misses the checkpoint. But once the first checkpoint is missed, our body tends to miss the other, this cell misses the other checkpoint. So eventually it grows to a point where it becomes like a parasite in our body, where as it grows, it tends to take the energy from our own body. And at some point, it reaches to a point where it wants to go up other places in the body. And it looks for places that is called a regional, where it tries to track through something called lymphatic system, because our body is interconnected with lots of what I call creeks, rivers, lakes, and these are the pathways from which the cancer cells can take. So I tell them, like, if it takes a local road, it can reach to a certain extent. If it takes a highway of the state, it can go anywhere it wants to go and get off anywhere it wants to get off. So I think inherently speaking, because the cancer forms within our body, just one of our cells, it has a way of traveling anywhere it wants to go. I think that's the simplest explanation I can give for that.
Yeah, thank you, Dr. Raghava. And that's why we really have to be on top of all the treatments so that we do not miss on anything and we are very proactive. So I think, Hannah, you have a question, private question. So please, I am reading the questions. If you can email me about the situation at lopa@breastcancerhub.org, that would be great since it's private, so I can answer you separately afterwards. And I'll definitely answer you back on that. So I think, Sohini, you have a question for me. As you mentioned at the beginning, that male doctors in India react to the concept of breast examination of patients irrespective of the problem for which the patient walked in. It's difficult to change the mindset of a society instantly. Rather, the upcoming doctors, med students should be conditioned in a way that they begin to make breast examination a regular clinical practice. What should be the strategy or kind of initiative to make it possible? So Sohini, that's what we are working on. So we are going to whoever I'm meeting, so we are trying to tell them. And also the other thing that I say and I request is, if all the clinics, you know, the private practices or all the gynecologists, all the doctors, the male doctors, female doctors, if they can have the breast self exam just posted in their clinics when the patient's waiting room, they're sitting there and they're seeing that, right, a big poster in front of their eyes. That is also like seeing also helps. That way that will break. And when definitely I'm requesting all the students, the medical students, they should come forward and they should break that inertia. Or what I'm doing is the other way, trying to, you know, teach, like, you know, make, empower all the women and men to go and speak up. You know, go and tell your doctor. And I'm very proud of one of the ambassadors, Magali. I don't know if she's here now. She recently went and spoke to her clinician that, can you do a breast exam, clinical breast exam for me? Though the clinician didn't come forward, she went and spoke. And that's what I want. If each of us can go and advocate, then the doctors will also feel comfortable about it because of the stigma and all the issues surrounding the word breast. I hope I could answer your question. So our next question is that, I think, okay, so I think it's, if any of you can see any more questions, I
There's
think.
one question, Lopa.
Yes,
I think
yes.
Sohini's again asked that. It's
Okay.
to me, can you please elaborate on the mapping of lymph nodes using
Yes.
the dye?
Yes.
Yeah, so Sohini, there's something called the Sentinel lymph node. And that's the first lymph node to which the cancer cells will spread from the main tumor in the breast. So when we do a lumpectomy, that is when we're not removing the whole breast, but we're just removing only the lump, then we want to know if the tumor has spread, some cells have gone to the first point of spread, that is the lymph node. So what we do is we inject a dye on the skin over the tumor and just rub the skin. This is at the time of surgery, just before we plan the removing the lump. And then we can see the dye because the lymph node, the lymphatics will immediately take that, pick up the dye and it'll go to the first point of spread. So there could be one node that is found, which is again having the dye in it. So it makes it very easy for us to identify that lymph node. And we remove it and send it for pathology. A frozen section is done. The pathologist will tell us if that is involved by the tumor. If that is not involved by tumor, it is very unlikely that it would have spread to other nodes in the axilla. So this is one of the ways in which we reduce the extent of surgery. So if that is involved, supposing we see tumor cells in that sentinel lymph node after mapping, then we go ahead and do the axillary dissection. We remove other nodes from the armpit. So that is a more extensive surgery. So by virtue of doing the sentinel lymph node biopsy, we've brought down the extent of dissection in the axilla.
Thank you so much, Dr. Sandhya. Sorry, I had missed that question and you brought it up. Really thankful to you. And I think Evey, you had a question, I missed it, was on the top, like what do you think about thermogram? So I know there's a lot of discussions on thermogram. So Dr. Raghava, Dr. Sandhya, and if you would like to chime in, or Dr. Nilanjan, yeah, Dr. Sandhya.
Yeah. Can I answer that?
Yes, absolutely.
Yeah. So we've just started doing this thermolytic scans in India now with this organization called Niramay. I think recently their paper was published in JCO where they've seen how it works as both for detection of symptomatic breast cancer and also detection of asymptomatic breast cancer. It's still not become the gold standard, but it's very, very useful because it's a no-touch technique, especially in a culture like India where people don't want to go and expose their breasts in a situation where there's a technician or somebody helping them, or a sonologist. So this is a no-touch, no-see kind of a technique that we have in India, and it does pick up hotspots. It shows areas of abnormality. But supposing there's a big, benign fibroadenoma, the thermolytic scan does not pick it up. So we have to use it judiciously along with clinical breast examination, but it's really a very, very useful imaging modality at the moment. There'll be, a lot more studies required and a lot more work to be done before we accept it as a primary screening modality. But it's very good as on record, along with clinical breast examination.
Thank you. Thank you so much, Dr. Sandhya, for answering. And I think with due respect to the speaker's time and, we would like to wrap up the session soon, and we will take the last question from Sohini. Is for Dr. Raghava. Is the concept of rogue cells missing the 2 checkpoints related to the concept of Knutson's 2-hit model? Sorry, you're on mute.
Yeah, I think that's certainly one of the theories. But I'm not a bench researcher or molecular scientist, but that is certainly one of the primary theories that explains how a normal cell becomes a cancer. But I think there's much more to be understood, because it's not just the missing the checkpoints, but what makes it what makes it to miss the first point. That means, for example, there are cancers like where we know the causative agent, whether it's smoking or Agent Orange or some of the chemicals that are in painting dyes, things like that. There are many cancers, majority of the cancers, we don't know that etiologic or the causative factor. So yes, from a mechanism standpoint, the 2-hit model is true, but what really triggers that first hit is what we still don't have a good understanding about. But I think as we go forward, there's a lot more research happening in the treatment aspects of cancer, unfortunately not as much in the prevention aspect of the cancer. So we may come a point where we have much better treatments. Cancer may be more of a chronic disease, and through education is where we could make a lot of inroads into outcomes on many cancers. I think that's where I think we see where we're heading in the next few decades.
Okay, thank you so much, Dr. Raghava. So I think we have answered all the questions on the chat room, and definitely, because I know all our guests here, all our speakers here, it's a Sunday morning and evening in India, so we already ran out of time answering the questions. But any other further questions you have, you can please email me at lopa@breastcancerhub.org, and I'm happy to answer. And also, if needed, I'll take the insights from our speakers too. So definitely we are open to more questions, but if you could email me for the further questions, that would be great. And saying that, I would like to really, really thank each of you here, all the guest participants and our honored speakers. Without you, this would not have been possible today. Thank you very much, Durga ji, Dr. Raghava, Sharon, Dr. Sandhya, Evey, Dr. Nilanjan, for your time today and giving, all the experiences, because I always feel that, we always learn more from the experiences of others rather than from the books. As Dr. Sandhya said, in our support group, we are learning so much, being a scientist, you being an oncologist, we don't experience that what our survivors, our patients are experiencing, and we are learning so much from each other. So saying that, thank you so much, each of you here, for your time, and really appreciate, and hopefully we will see you also for the other sessions. Thank you very much. Thank you.
Thank you. Thank you. Bye-bye.